name is Jordan Ciuro, and I'm the metastatic hormone-sensitive prostate cancer section editor on GU Oncology Now. So today I'd like to share some insights on an evolving treatment paradigm in metastatic HSPC, specifically when to choose doublet versus triplet therapy. So historically, our standard approach for metastatic HSPC was actually ADT monotherapy, which we now know is inferior care. Over the past decade, however, there has been evidence that shifted our practice, and we do recognize that intensifying therapy to at least a doublet therapy with an ADT and an ARSI has improved in survival, overall survival for our patients, as well as delayed disease progression. So what do I mean by doublet versus triplet intensification for our viewers today? So in the context of metastatic HSPC, doublet therapy typically refers to combining ADT monotherapy with an additional agent. Before there actually was approval for ADT with chemo, but we actually know that that's now inferior care if a patient is fit enough for chemo, they should be getting triplet therapy. So doublet now, today actually does refer to ADT with the addition of an ARSI or androgen receptor signaling inhibitor, such as abiraterone, enzalutamide, as well as, let's say, apalutamide. And there have been landmark trials like CHAARTED, STAMPEDE, TITAN, ENZAMET that really have shown that these combination therapies compared to single agent ADT has provided survival benefits. So today we should not be offering ADT monotherapy to our patients. And now switching gears, looking at triplet therapy. So what is this? This takes this concept a little bit further. And in a triplet regimen, we are combining ADT with both chemotherapy, specifically docetaxel, with an addition of an ARSI. Recent studies, most notably ARASENS and PEACE-1, ARASENS using chemotherapy, ADT as well as darolutamide, and PEACE-1 using ADT chemotherapy as well as abiraterone with prednisone. It really did explore the benefit of doublet compared to triplet therapy. And these studies do indicate that for select patients, specifically those with high volume disease who are fit and can actually tolerate the intensification of the addition of chemotherapy, the regimens do provide overall survival advantage. So I definitely recommend you, read ARASENS and PEACE-1 to really understand what that survival advantage truly is, but it's there. So really, the topic today is not really of the survival benefit, but really who should we be deciding to intensify therapy to? When do we decide doublet versus triplet therapy? Should it be triplet therapy for everybody? And I don't necessarily think that's the case, and I'm going to walk you through some questions I asked myself in clinic. And the first question I think is very important. It's going to be the disease burden. When we ask about what is the disease burden, we're really trying to decipher what patient has high volume disease. And based on the definitions of in STAMPEDE as well as CHAARTED, we do understand that high volume disease is really those patients that have the evidence of visceral metastasis or those with multiple bone metastasis. And it really has shown in both trials that intensifying therapy in these individuals with high volume disease has improved overall survival, and we should be doing this for our patients. And this intensification in high volume disease is not a new concept for us. When we look back to the CHAARTED trial, for example, it did show the benefit of adding docetaxel to ADT in those with higher volume disease. So again, it's no surprise here that those patients that have high volume disease intensifying with ADT, chemo, and an ARSI actually did have superior outcomes. But let's say you have a patient, which we commonly do, that is older, more frail, perhaps they're lower volume disease. Do these patients still benefit the same magnitude as those with high volume disease? And actually, we don't know. We need longer term follow-up in both ARASENS as well as PEACE-1 to really decide if there is overall survival advantage for these patients. So for someone that is more low volume disease, it really is a discussion with the patient to try to weigh the toxicity profile. The second question I think is very important that we as providers ask ourselves is, what is the patient's fitness and comorbidities? Because we do understand that intensifying treatment, we must weigh that against a patient's overall health and performance status, as we do with any treatment in oncology. Triplet therapy, by its very nature, it does come with an increased risk of adverse events. patients that are, let's say, younger, have fewer comorbidities, are in excellent performance status and walk into our office, I think those would be ideal candidates for a more aggressive triplet approach. But if we do have a more commonly an older individual, an older man that walks in, he has significant comorbidities. I do think that, and let's say he has a low volume disease, I do think that he might experience a disproportionate burden of toxicity from a triplet regimen with the addition of chemo compared to a doublet therapy. So therefore highlighting that a doublet therapy in this patient should be a more sensible option. But again, it's really up to you as a physician to tailor your therapy and have that conversation with your patient. So, we did talk about the tumor volume, the patient comorbidities, performance status. The third aspect I do ask, third question I ask myself in my office is what is the toxicity profile and what does a patient want regarding quality of life? Because we do know, that every additional agent in a regimen in any cancer type actually does introduce potential new toxicities. When we're looking at docetaxel, for instance, in this example, we know that docetaxel is chemo. It's not a benign drug, and patients that are on docetaxel, they do experience side effects such as neuropathy, myelosuppression, specifically neutropenia, as well as fatigue. And when we're looking at an ARSI, although they're relatively well tolerated, they do have an increased risk of cardiovascular events. We also have to be monitoring their liver function, and they also have, side effects such as increased fatigue as well. And when we're combining these two drugs, such as in triplet therapy, we have to understand that the cumulative toxicity might actually be significant in our patient, depending on what other drugs they may be on and what other comorbidities they have. So I think it's very important to have that conversation with our patients to really talk about whether it's really worth the treatment intensification when we're looking at the impact on their quality of life. And then the fourth topic, or question I think we should be asking ourselves in the office is really going to be a practical consideration such as cost and accessibility to our patients. Because, beyond clinical factors, I think that it's very, we have to be practical of the cost. Is the drug even available to our patient? Can the patient come to our office for frequent checks as well as, close toxicity monitoring? Because we do know that in some healthcare settings that the access to, let's say, an ARSI or perhaps, where the patient lives, if they live a couple hours away and they actually have to drive, 2-3 hours each way to come to the infusion center for the docetaxel to get those additional toxicity a profile management visits. I think it really is going to be at least a discussion with our patients to see if this is something that they want to pursue. And if you do have a patient that perhaps lives far away, they don't have the social support, they can't make it to frequent clinic visits for monitoring. I do think at least a doublet therapy, loop around every 3 months, with an oral pill that they take and coming in maybe at least monthly for lab checks or every 3 months once we get them on a good schedule, I think is more reasonable. So with that being said, we did talk about the tumor volume, also if it's de novo recurrent, de novo being more aggressive presentation, what, the patient's performance status is, what the patient expects for their quality of life, the cost to the patient, as well as the social support, and if they're actually able to come to the frequent clinic visits for monitoring. I do think that these are all questions we should be asking ourselves until we have more clear data, especially regarding those patients with low volume disease. But with that said, I do think, with that said, I think it's very important to understand that, you know, optimal treatment intensification is still evolving. There are ongoing trials to really not only redefine the timing of treatment, but also the sequencing and treatment intensification. And I'm really hoping that in the near future, we do have at least molecular biomarkers or genomic profiling, which might actually help us with a more personalized approach for our patients, allowing us to predict, which patients might actually benefit from doublet versus triplet therapy. But until we do, I do think it's very important to tailor our therapy to our patients to the best of our ability and have those difficult conversations. So in closing, I do feel that doublet and triplet intensification in metastatic HSPC, it really isn't a one-size-fits-all for the reasons I have, explained previously. But in my practice, what do I do at Emory? For those patients that are high volume, let's say de novo presentations, aggressive disease, who are otherwise, fit for triplet therapy, perhaps they're younger, great performance statuses. I do think that combining ADT with chemo, docetaxel, and either an ARSI with abiraterone or darolutamide, it actually does have the best chance of improving overall survival. But again, for those patients with low volume disease, who are maybe more vulnerable to treatment-related toxicity, perhaps older, I do think that doublet therapy still does provide an optimal balance between efficacy as well as quality of life. So with that, thank you so much for your attention. I hope this overview has provided a clear framework for considering doublet versus triplet therapy in a metastatic HSBC, and I'm happy to address any questions you have, and thank you so much for listening.